Hello, good morning, good afternoon, and good evening, everyone. Can you hear me? So can you give me some up if you can hear me clearly? Okay, can. Thank you. And first, thanks everyone for taking your time to join this webinar, the ripple effect, UK nice new threshold, and the future of global health technology. And my name is Wang Yi. I'm from the Swee Hock School of Public Health, National University of Singapore. And together with Sodamini Deepak from the Health Intervention and Technology Assessment Program Thailand, we will moderate this webinar together and hope all of us will have a fruitful session today. Next slide, please.
ตัวเป็นคนที่ไป
To
ตามที่กลับมานะครับแล้วจัดพิธีเสก
To start with, announcement for some general rules. We will be recording this meeting for internal purpose and will take pictures. To promote an open dialogue, we will apply the Chatham House rule, meaning participants may use the information from this webinar freely, but should not attribute the information directly to a speaker or participants in the public. But by doing this, we hope to create a comfortable platform for everyone to ask questions and respond to queries. So your voice matters. And the recording and the summary of the webinar will be made available. And next, let's start the webinar with a Zoom poll to understand everyone's opinion on this issue. So Rain, can you show the Zoom poll? Okay, the question is, so based on your opinion, what best describes your reaction to UK government's decision to raise its cost effectiveness threshold? So 5 options. So probably let's take 20 seconds to make your decision. So Rain, are we ready to show the results? Okay, so let's see. Oh, most people consider this one understandable but concerning. And oh, actually, most think it's too early to judge. And some people do consider this one is largely justified. Okay, so hopefully by going through this webinar, we will have all of us will have some further thinking on this issue. So let's continue. Ria, next slide. So the objective for this webinar today, we have 4 objectives. So firstly, we want to articulate the core evidence and debate surrounding the revised cost effectiveness threshold. And the second, to assess the potential pathways through which this policy shift could influencing the drug pricing and HTA deliberations in other places worldwide. And the third, to identify strategies and evidence to uphold sustainable context-specific decision-making in terms of international pricing pressure. And last but not least, connect with a global community of practice facing similar challenges. Next slide. So the expected outcomes. So by going through today's webinar, we hope we have better clarity on UK's decision, including the rationale, evidence, economic impact, and political and trade pressure. And we also aim to raise the awareness and prepare everyone for the potential global impact and challenges, including the direct and indirect pressure on pricing and the HTA process in other countries, developing evidence-based counter-arguments to safeguard the local health budget and the patient access, and also understand the interconnected issue of fair share pricing and international reference pricing. Next slide, please. Here is today's agenda. We will start with a welcome speech framing the global stakeholders. And following that, we have 2 sessions. For each session, we have 2 speakers. And following the 2 sessions, we have the interactive Q&A session and a strategy discussion. And at the end, we will close the webinar with a summary and a closed session. Next slide. And today we are honored to have five distinguished speakers with diverse background representing the decision makers, HT agency, academia, and industry. And we are also honored to have Beth Woos from the University of York as a discussant. And without further ado, so let's start this session today. Next slide. The first welcome session is by Dr. Swee. So he is the vice chairperson from HITAP and also the chair of some committees for development of the national list of essential medicine in Thailand. And he is also an expert on the issue for global health. So let's welcome Dr. Swee.
Thank you, Wang Yi. I'm sorry, I'm in China now, visiting the unseen general who helped Liu Bang to establish the Han Dynasty, the mighty dynasty that make China great today. It makes me think of the situation we are facing now. Big power is doing everything to get their own interest, which is logical in terms of humanity, although it's unreasonable. And we have to accept that when we make decision on essential drug list or benefit package, it will be meaningful only when our country has universal health coverage. And we have to make decision to include or to exclude certain drug and technology into the benefit package. If a country does not have universal health coverage, people on their own, health technology assessment will be much less useful. It's not at all unuseful, but it's not much less useful. And this webinar is very timely when the NICE, which is a globally recognized agency on health technology assessment, has changed their cost effectiveness threshold, and it stimulates concern all over. NICE, US FDA, WHO are example of globally recognized agency that can influence the norm and standard in developing countries. I want to say that CET is just one tool for us to make decisions. As I am the chair of the National Essential Drug List and also member of the universal coverage benefit package, we always have to make decisions. And CET is one of the tools we use, but not the only tool. We have other tools as well, and other evidences to make decisions. And for the government above us, they have other evidence, or other reason, other rationale to make decisions. When we say opportunity cost, we look at it from health sector, but the government may look at it from a broader economic factor. If you don't comply to the US demand, then you may lose your trade. Losing trade means losing national income and losing tax revenue, which feed into the universal health coverage system. So we have to balance all these interests and all these evidences. And the best for developing countries is to have their own capacity. A few months ago, World Health Organization decided to add GLP-1 agonist into its model list of essential drugs. This has put huge pressure, at least on me and on my members. Why we do not include GLP-1 agonist into our national essential drug list into the universal coverage benefit package when it is recommended by the WHO. I sent text through WhatsApp to the ADG and DG that, hey, are you protecting us? Are you trying to help us? Or are you going to pressure us for the benefit of the industry? There's no response. Of course, they don't want to put it in text, but informally, the response is country has the authority, has the national sovereignty to decide. The ratio is only advice. But your advice is influential and is used by the industry, even the civil society organization to pressure the government to put it in. This is the situation we are facing now. So how are we going to deal with it? European countries need to have its own economic evaluation capacity in order to inform the policy maker to make the appropriate decision. But once we have informed them and they have made the decision, the responsibility is their responsibility. So please enjoy this webinar. And I would like to sincerely thank the NUS School of Public Health and HITAP to organize this, which is under the Prince Mahidol Award Conference Strategic Institute umbrella, and also the funders to this work, which is the Thailand Research and Innovation and Development Fund, who support this webinar. Thank you so much. Please enjoy it and feel free to ask questions or discussion actively. Over to you, Wang Yi.
Thank you, Dr. Swee. Now let's start our session. So let's read slides. Okay, so our session 1 is the UK decision unpacked. And the first speaker of the session is John Spurs. He is the program director for commercial manager access and medicine policy at NICE. He brings extensive experiences in working closely with NHS England and also in developing and implementing strategies for patient access schemes, as well as broader commercial and manager access arrangements for medicine. So let's welcome John.
Thank you. And yes, so good morning, everyone, or indeed good afternoon or good evening, depending where you are in the world. So yeah, I'm John Spores. I'm the program director here at NICE. So just a massive thank you to our hosts today and also to our panelists. Very much looking forward to the discussion today. And as outlined just earlier, I think it's a really timely time to have this sort of discussion. So if we can move on to the next slide, please. So I think the first thing just to state is that the government here in the UK has initiated a program around support for the pharmaceutical sector that includes changes to the NICE threshold. Changes to improve the operating environment. So that was announced as part of the US-UK economic prosperity deal and also as part of the UK industrial strategy we have here. The goals from the UK government are very much around aiming to support the sector whilst preserving patient access. Here at NICE, we approve around 91% of medicines that we evaluate. On average, we kind of evaluate around 70 new products or indications a year. And we estimate that as a result of the changes, we would see around 3 to 5 additional approvals per year. So to be clear, NICE will deliver 2 commitments. One's a change to the cost effectiveness threshold, which is obviously the focus of today, used to develop TA guidance from 20 to 25 to 35K, and also to implement a new value set where the way we value health-related quality of life in health technology comparisons. So next slide, please. So what is changing then? So just a bit of background. I'm sure all of you are aware or who've joined the call that NICE does indeed use thresholds to decide which technologies are cost effective for use in the NHS. We have a standard threshold, currently 20k to 30k. That's going to change to 25 to 35,000 per QALY. And again, the aim there is to preserve patient access and emphasises NICE's role in supporting innovation. In terms of the delivery of this, it's going to apply to NICE's technology appraisal guidance. NICE actually has a number of other programs. So our technology appraisal guidance comes with something which we call a funding mandate. So if NICE recommends a technology for use on the NHS under the TA program, basically the NHS has 90 days to make the funding available. We also have non-mandated programs, so digital health tech and guidelines, and we're just waiting further detail from the government to see whether the new threshold will apply across those guidance delivery programs as well. We're not currently aware of any proposals to change the thresholds used to evaluate highly specialized technologies for ultra-rare diseases. So just to clarify, NICE also has a HST program where it has a higher cost per QALY threshold for ultra-rare diseases. And the Department of Health and Social Care and the Minister will consult on powers to direct NICE to enact this, subject to regulation change from April 2026. And I'll come on to that a bit later in my presentation. Next slide, please. So again, just quickly, we're focused on the threshold, but we thought just important just to clarify on the value set. So I'm sure you're aware we use EQ5D, 3L. A value set allows us to quantify health-related quality of life. That allows us to help compare treatments. It basically converts patient-reported health states into numerical value. We've got a new value set, which we think will help better capture the values of the public today, more sensitive, more cutting-edge methodology, and basically replaces the old study from the 1990s, which underpins the current approach. This value set, so the EQ5D5L and the value set alongside it, has been developed by asking 1,200 members of the public to judge different health states. That's currently going through independent peer review, and following the publication in 2026, we will then consult on the changes to the methods manual. So we thought that was important just to highlight alongside the threshold change. Next slide, please. So I think what's really quite important is it's often kind of just said, and you see in the media, that NICE is changing the threshold. I think it's really important to be crystal clear here that the Department of Health and Social Care, the ministry, plans to consult on powers to direct NICE to implement a new cost-effective threshold. Currently, NICE boards are the only body that can change the threshold, and as part of this shift to industrial strategy, to enable the department to do that, that requires a targeted change to parliamentary regulation. This change will clarify the status quo that ministers are directly responsible for the medicines budget, whilst NICE is responsible for the methodology. I think also really, really important to stress that any regulation change will not permit broader intervention in NICE methods or decisions, which is really important for us to ensure that we maintain our independence. So in terms of the timeline then, so the department has launched a consultation on the proposed regulation change. That closes on the 13th of January. In anticipation of that, prior to March, NICE planned to conduct a short consultation on how this change will be implemented. And then assuming, and you'll notice this is subject to consultation, assuming that the regulation change goes through Parliament and gives the Minister and the Department of Health and Social Care power to direct NICE on the threshold, we're anticipating in March that NICE will then be directed to implement the new threshold, and then from April 2026, as part of the NICE methods manual update, that will then be implemented. Okay, next slide, please. So that's the kind of hopeful sort of formal introduction. And I thought before sort of handing over to sort of Carl, we just a couple of additional points from my side. I think whilst we focus on today, I think it's really, really important to acknowledge that since NICE has been established in 1999, the threshold has always been under scrutiny and debate. So, you know, whether it was the early 2000s, you know, all the way through to we've had the end of life criteria, we've had the highly specialized technology threshold, we've had severity modifiers replacing the end of life criteria in 2022, we've had the Cancer Drugs Fund, we've had a revised Cancer Drugs Fund, we've had an Innovative Medicines Fund. Fund. And I guess what I'm saying here is that, like, when we're focusing today around the threshold change, it's really important to take the longitudinal view. I think Professor Andrew Briggs in his blog called it quiet drift. But what's really, really important is, we're on a journey. NICE doesn't exist in a vacuum. And it's really important that when we look to the past, really important that we consider that kind of longitudinal sort of policy in terms of where we're going as well. My colleague, Dr. Jack Bruvy's written a great blog. It's available on the NICE website. And, she talks through there, around the debate that's continued, and very much looking forward to hearing from Carl and other colleagues later this morning. But NICE's focus remains clear that, we need to balance innovation with financial sustainability. But most importantly, which is why we are here, is to deliver the best possible outcomes for patients. And that's really, really super important. So if we could go to the next slide, please. And from my side, I think it's really, really important that we're focusing on the number, the shiny number. We always focus on that. But what's really, really important is that for HTA to continue to thrive, it's important that we retain the core founding principles that sit underneath it. And that's to ensure we're patient focused, we deliver the best care to people fast, whilst ensuring value for the taxpayer. And I can never find a way to describe this better than the word soul. I don't know what it is in Thai, it means sahi in Greek. But basically it's what makes us special in terms of HTA. And that's having an evidence-based academic spine to our policy, making sure that we're transparent and that all our engagement is around robust stakeholder engagement. And most important, that we have independence and rigor. And whilst it's important to focus on the threshold change, it's super, super important that we don't forget the principles that kind of make us special in HTA. NICE has survived 25 years. We're very much looking forward to another future 25 years. But if you start to dilute these kind of principles that sit behind NICE, we simply become yet another regulatory barrier, as does HTA, that can be diluted over time. So that's why, yes, the threshold's important. Very, very much looking forward to the debate today. But let us not forget the founding principles that sit underneath it, because that's super, super, super important. Okay, next slide, please. So then just to finish then in terms of conclusion, so the UK government has announced that it will increase the threshold NICE uses in its evaluations of new medicines to determine which are cost effective for use in the NHS. That change is going to be implemented from 2026, and that's designed to improve the operating environment for the pharmaceutical companies in the UK and maximise the government's commitment to unlock innovation and support the sector. As I said, the NICE threshold, and as outlined in the introductory remarks as well, has been highly visible and subject to scrutiny since the organisation was founded in 1999. NICE doesn't exist in a vacuum and has evolved over time. And I think it's really, really important, whether you are based in NHS, international organisations, industry. We were reflecting in our early session before we joined the call about the need to have a calm and stable operating environment. You turn on the TV at the moment and the world just seems so chaotic. And I think it's really, really important that, again, those principles, that calmness, that ability to have a stable operating environment is super, super important, not only for NHS and health systems, but also for industry colleagues to ensure that they have a stable environment to develop and launch medicines. And then finally, as I said, whilst the headline focus is on the threshold increase, it's super, super important that we don't forget the core principles on which HTA was founded. And if I can put that another way, whilst methods and processes can change over time, our principles should absolutely not. Thank you.
Thanks, John, for sharing your insight. Our next speaker is Dr. Carl Glaston. He is the professor in the Department of Economics and Related Studies and also a senior research fellow at the Center for Health Economics, University of York. He has previously served as a member of the NICE Appraisal Committee and also is internationally recognized for his seminal contributions to the evidence-based underpinning cost-effectiveness threshold and opportunity cost in healthcare decision-making. So let's welcome Carl.
Thank you so much. Next slide, please. Yeah, thank you so much for this opportunity. I think this webinar is really timely and I think really important. Really important debate in the UK, or policy, the importance of the scrutiny, appropriate scrutiny of policy in the UK, but also has much wider implications. So thank you very much for organising this. Just before I start getting into what the benefits and costs of this so-called deal really are, just to pick up on what John said, John's quite right that over time, NICE and the threshold that it's used has been moved and tweaked for different reasons. And we've got to remember that the original NICE threshold of £20,000 to £30,000 wasn't based on any evidence of what the impact of additional costs are going to be on the NHS. It was actually based on a paper published by Mike Rawlings and Tony Collier, which basically looked at what we as a committee had done in those first few years. So the existing NICE threshold isn't really based on any good evidence. It was, as we're going to see, it was too high, set too high then. It remains too high now. So what's going on in the UK isn't just about changing the NICE threshold, because as we're going to see, it's really about the scale of the impact of this particular policy change. So what are the benefits and costs of this so-called deal? Well, on the benefits side, what's been publicly claimed is that it's going to provide access to new medicines, it's going to avoid the threats of US tariffs on UK drugs, encourage innovation and make sure we pay our fair share to reward innovation. It's going to encourage inward investment in the UK, and it's going to support our life sciences sector. So those are the publicly claimed benefits of this deal. But what will it cost? That's actually quite difficult to find out because the details of the deal have not been made public, nor has the impact assessment. Our Minister of Health says it will cost an additional £1 billion per year by the end of 2028. We do know about the deal is that there is a minimum target expenditure before 2029, and that's an additional 1.18 billion in that year. In other words, the minister's right in terms of the minimum target if you round it down to the nearest billion. But what have other people said? Our Minister of Science, what they have said on the public record suggests that it's going to be 6 billion. And the reports from the British pharmaceutical industry that have not been contradicted by government suggest that it's going to cost an additional 7 billion each year. And that is not simply a change in the NICE threshold. It is a combination of changing the NICE threshold, but also reducing the rebates that we get back. How long will it take to reach this 6 or 7 billion? Well, certainly no more than 13 years and more likely 10. And then we've got to ask the question, what's going to happen when this deal is renegotiated before the end of 2028? So, next slide, please. So, what are the real costs of every extra £1 billion that we have to spend on new drugs? We know quite a lot about that. We can say that an extra £1 billion is going to cost an additional 6,000 to 7,000 additional deaths in the NHS. And if we combine the impacts on NHS outcomes and adult social care, we can say that we're going to lose somewhere in the region of 150,000 quality adjusted life years. We also have good evidence of the impact of that on local economic growth, and we'd also expect to lose something in the region of 6 to 9 billion pounds in local economic growth. And if we value both the health effects in terms of value the health effects the way that using values from our own treasury, the overall losses to the UK, combining the value of the health impacts and the impacts on local economic growth, is somewhere between 17 and 20 billion pounds. Next slide. So where do we get these estimates from? Well, over time, over the last 10 years, we have built a quite considerable body of causal evidence that's looked at the causal effects of changes in NHS expenditure on health outcomes, particularly mortality, but also quality adjusted life years. So next click. What does that evidence tell us? It costs something less than £10,000 to improve health by one quality adjusted life year in the UK, and it costs less to improve health now than it did in 2010. What is that telling us? When our UK Treasury values a quality adjusted life year not at £10,000 but at £70,000, what is that telling us? It's telling us that the increasing healthcare need and more effective medicine has outpaced the impact of increased NHS funding. It means that the NHS is increasingly underfunded based on Treasury valuations. It tells us that costs imposed on the NHS reduce health and also increase health inequality. So even at current NICE thresholds, before the increase, it means that we're already doing more harm than good when we approve a new drug for widespread use with the funding mandate, which means that those drugs have to be funded at a local level. Next click. What about the impact on social care, a really important sector in the UK? Again, we've got a body of causal evidence. Next click. In fact, next 2 clicks. What does that causal evidence tell us? Well, it tells us that social care expenditure makes the NHS much more efficient and actually reduces mortality. Social care expenditure increases the quality of life of users and their unpaid carers. It reduces anxiety and depression, and it has quite a significant impact on local economic growth. Short-run multipliers of between 6 and 7, and much bigger, longer-run multipliers that actually most of that long-run effect actually we receive in the relatively short term, most of it within 6 years. So when the NHS is forced to pay more for new drugs, it's going to increase the need for social care. Every £1 billion of additional NHS cost is going to increase the costs of adult social care by about 120 million each year. It's going to lead to worse quality of life outcomes for users, their unpaid carers, increase anxiety, depression, and we're going to reduce economic growth. Next click. Now, right now, we don't know whether the NHS is going to have to pick up this bill or whether the money will be found from Treasury. But even if Treasury finds the money and the NHS doesn't have to pick up this bill, the question still remains, is it a good use of public funds? What else could that additional billion or 7 billion in 8-10 years' time, what could have that been used for? And I won't labour this slide because I know we're short on time. But if you just take a look at the bottom line, the bottom row, that tells you something about the value of one public pound in terms of the Treasury valuation of the effects. And what you can see is that if you have additional money to spend, there are much better ways to spend it than simply increasing how much you spend on new drugs. For the NHS, the value of one NHS pound is somewhere between 17 and 20 pounds of value you get. For adult social care, it's even better value, somewhere between 30 and 40 pounds for every pound you spend. So whether the NHS picks up this bill or Treasury picks up this bill, it doesn't look like a particularly good use of public funds. Let's take the next slide. Next click. So what are the likely costs of this deal? And it's a combination of a change in threshold and a reduction in rebate payments. That's going to amount to 7 billion over something like a 10-year period. And this is what you can see here, how those costs are going to build over time. What we don't know is what the other changes, the impact of the other changes, the changes to the value set, how they're going to change budget impact assessment, what they're going to do to the Cancer Drugs Fund, what this means for ultra-rare diseases, etc., etc., etc. So I believe that these are probably quite conservative estimates of the additional cost. Next click. Oh, please could you just remove the text to the right away from these columns that have just been revealed? Just delete that. Delete that box. There we go. Thank you. Sorry, that was my fault. Thank you very much. Click, click. Forward. Next one. Could you put that on slide view? Okay, I'll speak to this slide.
Yeah, thank you. We can continue with the current version if that's okay, Carl.
Okay,
Thank you.
apologies, that was my fault with the animation. This is an attempt to show something about the scale of the impact. So we can see how the costs of this deal build over time. And on the far right, we can see how this compares in terms of the additional deaths that we can expect, the excess deaths as a consequence, based on our low estimates, and how those build over time. And just to give context, we're expressing those on the far right as a percentage of the additional excess deaths during the 2 periods, during the 2 years of the COVID pandemic. And what you can see is that over 8 years, we are going to have greater excess deaths as a consequence of this deal than we did during COVID. Next click. Is it okay to put on slide view? Thank you. What about the benefits? Are we going to get access to new drugs? Well, as John's already said, we already approved 91% of them. So at best, we're going to get an extra 2, 3, 4, 5 drugs approved. But at the price of those drugs, we know that we're going to be doing more harm than good. And we could have got those drugs anyway had we had a suitable pharmaceutical pricing mechanism. Next click. Does the impact that this deal might have on investment justify it? Well, let's be clear. R&D investments are for a global market, not the UK market. What determines investment is the research environment and infrastructure, the costs and the business environment. For example, AstraZeneca relocated its manufacturing to Ireland some 10 years ago. It didn't do that because Ireland was a big market or they paid high prices for their products. It did it because Ireland reduced their corporation tax rates. It does depend on tariffs and threats of tariffs, but compared to other locations, the rest of the world is facing 100% tariff. We've done a deal to get 0%. Next click. Maybe the geopolitics are too difficult. And let's be clear, new drugs are unaffordable, especially in the United States. And that's not going to go away. And that creates political pressure in the United States. And currently the deal is lower US drug prices, but in return, increase the price that the rest of the world has to pay. That's partly based on a narrative that the rest of the world needs to pay their fair share to support innovation. Now, the UK has been the first target of this geopolitical pressure, but it won't be the last. In fact, we've already seen it with France. It won't be the end of the pressure to pay more. The idea that we can just wait for Mr. Trump to cease to be president and this will go away, I think is profoundly naive. The pressures in the US healthcare system built under Biden, it's Biden that introduced the Inflation Reduction Act. This will not go away. And it will not be restricted to high-income countries. Next click. What about this idea of are we paying our fair share? Well, again, Beth has led work on this area. what do we find? Well, it turns out we're already paying much more than our fair share. And so are US citizens and many other countries around the world. In most cases, we're paying more than 100% of the very long-term value of new drugs. The evidence of how the quantity of innovation responds to payment suggests that we should be paying something like 20%. On average, we're paying more than 50%. So we're already paying more than our fair share. We're over-rewarding innovation as it is. Next click. Can the threat of tariffs on the UK pharmaceutical sector justify this? This is showing you the losses of an extra 1 billion relative to the value of the sector, the exports, the pharmaceutical sector, and the entire life sciences sector. Now, what this is telling you is that the value of the losses, even if we just focus on the GDP effects, the losses to GVA on the far right, they're greater than the value of the entire sector. So it's not plausible that the threat of the impacts of tariffs or threatened disinvestments alone could make this worthwhile. Next click. So what are the real reasons? What are the real reasons? Well, at the moment, many FTSE 100 companies are undertaking listing reviews. Why? Because your valuation to profit, your it's headquartered and registered in the UK, hasn't paid corporation tax here for many years, has received public support, but its major shareholders are US. So, in part, this deal may be to protect the interests of the London Stock Exchange and the financial sector. So, why is it that they've targeted NICE thresholds and NICE methods? They didn't have to change the NICE threshold to give the pharmaceutical sector more revenue. They could have just changed the rebate mechanism, but they've targeted the threshold. Why? I believe it's to remove the independence, and that is why they've pushed for a vote in Parliament. It requires a vote in Parliament. They didn't need to do that. It seems that they want to remove NICE's independence, but at the moment maintain it as the primary route to market access through its funding mandate. But I think what we have to recognise, and I think John pointed to it, is that there is a very real risk here that actually HTA actually becomes irrelevant. If you can provide another route to market access, then HTA just becomes a regulatory barrier. Next click, and I'm going to stop because I've overrun on time. I think there are practical evidence-based solutions that we can start to look to. But now's the time to look more radically at how we link the evidence from HTA that John talked about to a practical, sustainable reward and pricing mechanism for pharmaceuticals. Thank you. I'm sorry that I've overrun a little.
Thank you, Carl. Now let's move to our session 2, the international ripple effect. So the first speaker of this session is Associate Professor Vanruti Isra Nuwachai. So she is the director of HITAP. So let's welcome Vanruti.
Thank you, Dr. Van Yi. In Thailand, when we think about health technologies at HTA, we do think about and in a way look up to UK. And it's not because they are nice, but truly because we do see them in many ways as role model. And now as part of HTA, we often think about cost effectiveness threshold. And we also then think about UK. Specifically, we think about William Shakespeare, Hamlet, who said, who has a famous quote of to increase or not to increase. That is the question. And in many ways, this is the question that we've been asked regularly in stakeholder meeting or at subcommittee meeting, working group meeting on many occasions by policymaker and many other groups. And it's not surprising that we've been asked of this question a lot, mainly because HTA has been used to support the development of health benefit package in Thailand in many through many different channels, such as in the development of the national list of essential medicine, the list of essential vaccine, benefit package, non-drug, non-vaccine. So HTA has been around to support this. Now, up until now, and according to what John said, would be until April 2026. I'd like to share, like, we always think that Thailand has a unique case. Not because we have an explicit threshold, because UK also has that. But to our knowledge, Thailand has increased to the threshold not once, but twice. But we understand that very soon that will no longer be a unique case. So allow me to share with you more so an unique case, which is that we started the use of the threshold in 2008 with the threshold of 100,000 Thai baht per quality gain. And then we increased it in 2010 to 120,000 Thai baht. And we increased it again in 2013 to 160,000 Thai baht. So yes, we have been using the same threshold for the past 12 years. So you may not be surprised that we've been asked quite a bit about whether to increase the threshold or not. And some information, so yes, one GDP for Thailand is around 250,000 Thai baht. So because we've been asked a lot and people are saying, shouldn't it be time now that we increase the threshold? We at HITAP have been commissioned by the National Drug Subcommittee to conduct a study to answer that question. But along with Dr. Yot and our team, we make a case to the subcommittee that let's look at this. Well, back then was a unique case, right? Unique case that we have. Instead of jumping to ask the question of should we what should the new threshold be? Should we increase? Don't we want to know what happened when we actually increase the threshold? So that's what we did. We answered the question of does an increase in cost effectiveness threshold increase the chance that high cost drugs will be included in the national list of essential medicine? It's a secondary data analysis. We look at all drugs submitted for consideration by the subcommittee from 2008 to 2020. In total, we have around 250 observations. It's a collaboration across many different groups, including with Dr. Wang Yi from NUS as well. So what did we find? Well, we did find that drugs submitted when in the period where the threshold is highest, so at 160,000 Thai baht, they have 1.6 times higher or more chance to be included in the national list of essential medicine. But you can also see the bulleted part that these findings are not statistically significant. So we did present all this information to the subcommittee, where the chair of the benefit package subcommittee also agree with our next step, which is we should wait for the study on health opportunity cost, following the approach that Professor Claxton had been talking about. So we are a big fan and we are waiting for that. So right now, if I can maybe share with you a little bit before go to my last slide in terms of the core principle, because it will be relevant shortly. The core principle when we develop benefit package in Thailand include systematic. The process should be systematic, should be transparent, which makes sense. We also want to ensure that the process evidence informed, not just evidence based, but evidence informed. As Dr. Suvit highlighted, there are many decision criteria, as you can see in the bottom right, not just cost effectiveness. Cost effectiveness is only one criteria. But the other core principle is participatory, which is very important. It is something that as an HITAP and all the HCA researcher in Thailand aim to do, which is to ensure that we work closely with all relevant stakeholders. So when we think about potential impact of nice new threshold, then we have a few thoughts and questions I like to share. The first one is really stakeholder engagement has always been considered as a really good thing. So in this case, based on what John kind of shared and what we read, well, we got really good engagement with stakeholder, in this case, policymakers. So it also makes us look back to what happened in Thailand. If we actually get policymakers to also care about health technology assessment on many days, we would consider that a win. We're very fortunate at the moment to have Dr. Swee, who is also very well aware and familiar with health technology assessment. But not all policymakers or decision makers are like that. So for us, if something like that, like this, something similar were to happen, would this be a good thing? How do we actually balance by being successful to engage with policymakers, but at the same time managing the expectation and ensuring that they actually see the evidence for what it is and not take it to support their own agenda? Because when we change subcommittee every 3 years, in many ways, HTA research in Thailand, we start from scratch. We have to always try to engage with stakeholders. So that kind of like the first thought that we have. And the second one was around looking at lesson learned and, having this platform. We really appreciate all the speaker, the experience that all of you shares with us. The open letter to the government, to the Prime Minister by Professor Claxton and Professor Scoffer, like truly, it is an inspiration. Dr. Martin Luther King once said, "Our life begins to end the day we become silent about things that matters." And listening already to the two speakers, and I'm certain to the next speaker, we know that what we're talking about, it matters. And when we come across situations like this, we do hope we have the courage, like yourself, not to be silent, but to do something more about it. And I think that's a very valuable message and lesson for us. But last but not least is also we had start to think about how we can get ready because they are coming. If we think about how many times people have asked us to increase the threshold, we're certain that very soon the number of requests to increase the threshold will go up. And the request will no longer just be a question, should we increase the threshold? It would be, we should increase the threshold. Look at what UK and NICE are doing. Even though I know, John, you did say that it was not NICE who decided to use, but people will remove a couple of words to say that, look at what NICE is doing. And then, so based on, especially with all the really great evidence research that Carl just mentioned, we know there are reasons to believe why we should not just increase threshold when we don't know what it should be yet for Thailand. So our initial plan is really to hold on tight and believe in the evidence. But is that it? Would that be enough? And I'm very excited to be part of this webinar to also learn from all the speakers, from all the questions. So if anyone have any other suggestion for countries who are in many ways always pressured to increase the threshold, and now with this situation, would really like to hear your thought. Because after all of us, we are in this together. So thank you very much.
Thank you, Varudi, for sharing the unique case from Thailand. So now Thailand won't be the unique one in changing the threshold, but potentially researchers can look at the impact in both Thailand and UK, which hopefully can inform their decisions. So our next speaker is Polka Swee. She's the partner and head of life science from Ventura Consulting. So she will share industry perspectives and insights drawn from her extensive work at the interface of strategy, policy, and market access across Europe and Asia. So pass to you, Polka.
Thanks very much, Billy. And I really like the discussion and as set by Carl and John and Warren G, this topic really come at the timely point. So thanks very much for the host and panelists discussion. So I'm going to talk about the global impact of the NICE cost effectiveness threshold adaptation. So next slide, please. So yeah, this is just a quick recap. John has provided much better overview than I would do here. So NICE will increase the CET, so effectively in 4 months, so in 2026. So, and John also mentioned this change on the highly specialized medicine, etc. So we focus on the top part. So next slide, please. Yeah, so the NICE methodology and appraisals are recognized and followed around the world. So consequently, this is not just one event in UK only. It does have a global impact. And as Professor Wang Rudi already said, the impact itself, of course, will vary. It depends on what methodologies, what countries use, whether a country use a global benchmark to shape their national cost-effective threshold, and then whether NICE has an influence on the price negotiation. Nevertheless, what I really want to emphasize here is, so with this one event, landmark event, right? So from UK, the orange part visualize the potential impact it may have on the global scale. So for UK, John said before, estimation is 3 to 5 new drugs will be recommended future by NICE. So what I want to say is, Carl mentioned UK is the first one, but will not be the last one. So with one event, we see a significant proportion of the global map gets impacted. So later on, when we have maybe more events, so the dynamic change quite significantly in the future. Next click, please. So what is the impact for UK? So increasing the UK CET expands the domestic competitiveness. So it does incentivize high value innovation and also set new benchmark for price and policy now worldwide. So for UK, we could argue that it does improve the market access for innovative therapies, maybe for a smaller proportion of patients. And in the long run, there's going to incentivize the R&D and also encourage investments, for example, in UK. It does, however, put pressure on the budget. So it will or may restrain the payer sustainability for the long run. And their pharmaceutical companies, manufacturers may anchor price to a higher threshold following the CET uplift. Next click. And from a manufacturer perspective, this is not just UK, so it does have a global impact. It could potentially boost the global competitiveness and market prioritization, but also has a ripple effect, which is why we are here today to also discuss and debate on the ripple effect on the pricing and policy alignment. So what does it mean for industry? So it could raise launch attractiveness, given now there will be a higher threshold, and turn some of the countries into a priority market when pharmaceutical companies plan their launch or market access strategy. And if you look at the lower left, it also supports pharmaceutical policy ambition in general. So by reinforcing the global competitiveness, so that the industry, the countries, right, they can foster innovation and adapt those evolving standards, so that countries can remain its leadership in research, in R&D, and market access, because more funding or prioritization might be made towards those countries. On the upper right-hand side, you can also see it does have also the reference pricing spillover, so which makes it which might make it more difficult actually for industry to manage because there are so many dynamics. It may affect the affordability, so may make the negotiation, the reimbursement and negotiation more complex. Therefore, due to all those more complex process, effectively, it might even delay the patient access to a given drug. And the approach from divergence from opportunity costs currently that it may increase the inconsistency for pharmaceutical companies. So eventually it makes it harder, it might make it harder to even predict what is the market access conditions, let's say in 3 years or in 5 years. And next click. So by lifting the UK cost effectiveness threshold, it could boost the adoption momentum and also pricing benchmark in Asia. So making manufacturers to rethink its global pricing and market access strategies for their innovative drugs. So it influenced the adoption of innovative therapies now from this positive correlation between NICE approval and reimbursed approval that I think Professor Wangruti just mentioned that we see in Thailand when the CET raised to 160,000 Thai baht, it has 1.6 times more likelihood to get reimbursed. So that does, at least from the Thai experience, that we can see there's a positive influence on the adoption of the innovative therapy, which will, of course, shape the industry decision. And also, secondly, it drives a global momentum for approvals, so it resulting in a faster uptake and of the new treatment from a global perspective. And it does increase the upward pressure on the international list price because of the threshold now boost by 25%. It also promotes some of the HTA bodies now to apply maybe a stricter price, volume, or risk share agreement. I think Wangruti just shared the 5 things that different criteria the Thai HTA may consider when making those decisions. So it also, put more pressure for local agencies to build this really local HTA capacity to in amid of our potential this geopolitical events as well. So I think this summarizes what I want to share for now. Now, hand back to you, Billy.
Thank you, Polka, and thanks for all the speakers for your great talk. And next, I will pass to Sadamini to lead the Q&A session.
Thank you, Dr. Wangi, and thank you again to all the speakers. Wow, this has really been a treat and a great start to the year. One thing to get before we dive into the questions for all our speakers, we have a discussant here, Beth Woods, who is a senior research fellow at the University of York, who will share a bit of her perspective based on her recent work. Beth, over to you.
Thanks very much, and thanks for a really fascinating start to the day here in the UK. So I've been asked to say just a few words about our research on global pricing. So we've been developing at York quantitative models that look at the collective impact of individual countries' pharmaceutical pricing policies. So we've been looking at what those mean for countries' local health systems in terms of their ability to provide other forms of care, but also what those pricing policies mean in terms of stimulating global innovation, the development of new drugs, and therefore health benefits in the future, and what this is expected to mean for individual countries. So I wanted to highlight a couple of key findings from that research. So the first finding is that even when we take into account these important benefits of higher thresholds in terms of driving innovation, what we see is that when we have higher politically determined cost effectiveness thresholds, such as those that we have in the UK, that delivers lower population health internationally than when we have opportunity cost-based cost effectiveness thresholds. And interestingly, that's even observed in the USA. So I think that's really important, that even when we take into account those innovation benefits, if what we care about is maximizing long-term population health, opportunity cost-based thresholds get us to a better place. What we also see is if we want to align the prices paid by individual countries with the value that those countries receive from pharmaceutical innovation and new medicines, we do need to see high levels of price differentiation. And so policies like the most favored nation policy, that's obviously driving a lot of the developments we're observing, those aim to move away from high degrees of price differentiation and towards much more harmonized prices. And what we see is that when we simulate the effects of those policies, we see countries outside the US paying far more than their fair share for pharmaceuticals. And I think that provides an important line of defense and counterpoint to the argument that harmonizing prices is the fair approach, and that actually a fair approach is to have high levels of price differentiation. I'll stop there because I know we have many great questions in the Q&A, but if anybody's interested in our research in this area, please feel free to get in touch.
Thank you so much, Beth, for giving that perspective on fair pricing. We are now going to turn to our speakers. Please do share any questions that you might have. We already have a few in the Q&A, but please, for others, do add your questions. And if not, during the next half hour or so, we will try to get back separately. So perhaps I'll start with John, who has been responding online as well to questions. But with your closing remark about the soul of NICE and some of the questions in the Q&A about principles that NICE stands for, and as Carl also showed from his based on his analyses, that about NICE's mandate not only being limited, currently perhaps limited to the NHS, but not the effect of this change is felt across the system, and someone else is going to have to bear the cost. So could you elaborate a little bit about NICE's principles in this changing context, and also whether this is really such an inflection point, or has this been happening over the past few years, and now it is really coming to a head? So over to you, John, first.
Yeah, thanks so much. Yeah, so a few things there. So I think in terms of the, I see there's also a question around, do we have the question around the institutional position on political power as a normative tool to such as the cost effectiveness threshold. I think it's really important that I'm a non-elected official. There's 800 people at NICE academics, a range of staff who probably have lots of views. Carl knows that I'm a massive fan of his work as well, as does Beth. But I think it's really important that we have a democratically elected government that, as a result of a number of factors, including the life science sector plan, the US trade negotiation, have decided on this sort of policy. And I think that's really, really important. So whilst we advise the academic community in daily critique, that's the journey we're on. I think, secondly, to your point, I really do focus on the principles. So I think both Poka showed in her presentation, hopefully I did in mine, that, we're looking at longitudinal trends as well, and NICE are still here. The principles are so important that HTA continues to thrive and survive. And, yes, this change has implications for the threshold moving up. But I think, within that, NICE still has independence, rigor over its methods and processes. And, Beth's talked around some of the academic work that she's been doing to help sort of continue to shape that. So I think moving forward, the key question really is how we continue to make sure that HTA continues to evolve in the right direction. And that comes back to our core purpose, which is to make sure we're improving patients' lives and making sure that we're patient-centric, and that the principles aren't compromised. Because once the principles start being compromised, you start ignoring academic and evidence-based solutions. You start moving away from transparency and stakeholder engagement. I think that takes you down a dangerous path. And crucially, and I noticed there was a question in the comment around, well, couldn't the government, how regularly would they then change the threshold? The other point to my presentation was stability. We need a calm, operating, stable environment in the UK that gives us not only the headspace to check in that we're doing the right thing, but also that gives industry and the NHS, a stable environment to ensure that we can plan for the implementation of these technologies. Because I think what's really, really important is HTA, and I think it was mentioned in one of the presentations, is one part of the jigsaw puzzle. We evaluate whether they're clinically and cost effective. The NHS, the health system, then has to get those ready to deliver. And that's really, really important again. So that stable, calm operating environment helps the NHS plan for the implementation of these technologies, which in my mind is as important as the HTA. I notice Carl's also got his hand up. Carl.
Thank you so much, John, for your response. And in your earlier remarks, you did say that you're looking forward to a debate. So I think this is a good time to open it up. And perhaps, Carl, over to you first, and then we'll go forward.
Just to be clear, I'm a big fan of John, actually. Before I say anything else, I just to respond to John, the idea that this is the reasonable outcome of a democratic, accountable process that reflects the values and the wishes of the people that our parliament is supposed to serve, I profoundly reject. I think the experience has been appalling over recent months. There is no impact assessment. The deal itself is not a public document, not published. The costs are unknown. The minister has not said it's £1 billion in Parliament, because if he lies in Parliament, he will lose his job. But he has said it all over the media. We don't know what the costs are. We're having to surmise them. There's no impact assessment. The benefits that have been stated in all the public presentation of how good a deal this is, they're all false. We can show that they're false. The true costs have not been aired or even discussed. And the real reason that this deal was done, know it, and I'm willing to bet significant body part on America threatening to delist from the London Stock Exchange buried. Have a democracy when the key things on the table are being hidden from those you're supposed to serve, including Parliament and parliamentary backbenchers. So the idea that this is somehow legitimate because it's come about through some kind of democratic process, I profoundly reject. If all of that had been done and there was a vote in Parliament, there will not be a vote in Parliament. The only vote in Parliament will be whether you give ministers power to instruct NICE. And as I understand it, not just over the threshold, but over key issues and methodology that ministers deem important enough to instruct NICE over. So, yeah, so I don't think this is business as usual. This is existential. And I don't think I'm being over dramatic. I've been around a long time and I've seen some cynical stuff. I've seen some incompetent stuff. I've seen some downright bad stuff. I've seen missed opportunities over many, many years. This is different. It's different in scale. It's different in its domestic consequences, and it's different in its global consequences.
Thank you, Carl.
I would say it's an existential threat. It's an existential threat So nice. Sorry.
It's a very sobering thought, and I think it's important, and that's why, as many of you have already said, this is part of the reason why we wanted to have this webinar, and all of you, even at the close end of the year, were willing to step in and step up to have this discussion. So thank you, Carl. We'll come back to you in a bit, but perhaps first we'll turn to Poka. I think there's a question directed to you in terms of how this has impacted industry's approach in other settings, particularly in low and middle income countries. I think you did reflect on it a bit, but would like to perhaps hear a bit more from you before hearing from others. Over to you.
Yeah, sure. Sure, thanks, Sulamini. So the question is whether the industry is welcoming this change also in low middle income countries. So I think what I have learned back then in my business school is the answer to every question is it depends. What it depends on. So let's say everything equal, then uplifting the threshold. I think the data from WRD was self-explanatory, that uplift the threshold improves the chance to get reimbursed. Then would industry welcome this change? Yes, but there's no such a thing common as a free lunch in the business world. So the question is really how the threshold is determined, whether it comes at the cost of intransparency, which then adds the cost to doing business for anyone in the industry, and also uplift the threshold. It might overcompensate innovation. So the consequence of that is the other side of the industry, for example, those providing more cost-effective services, such as surgery or social care, as Carl said, or generic companies, they might need to bear the cost. So there is no general answer, say whether industry will welcome it. It really depends on how it's made and who is the actually ultimate beneficiary, because it will come at cost for the other part of the story.
Thank you, Poka. And I'm thinking, actually building on your point, to perhaps invite Beth in again to bring in the other side of it for the pharmaceutical perspective, especially since a big driver for this decision has been around innovation, whether it's domestically, and Poka, you also alluded to that in your presentation. So Beth, any additional reflection based on this point that Poka responded to on the differences across contexts?
I think it's key to remember. I think something that Carl stated towards the end of his presentation, which is that although a higher threshold may in some situations give us access to more medicines, the main effect in lots of countries will be that we pay more for what we're already getting, and that may be a huge cost in a lot of settings. So in the UK, for example, we're approving 90% of medicines. Changing the threshold may mean we get a few more medicines approved. But the main effect will be that increase in the drugs budget across the 90% of medicines that are already getting approved. And I think that's really key, and that's where that message around the large opportunity costs compared to the gains is really coming from.
Yeah, and I also would like to maybe just to add what Beth you just said. It also depends on the context a certain country is in. The country also have a different priorities. For example, for now, UK has the priority, say we want it to be a launch priority for pharma industry. But then for some other countries, for example, low middle income countries, specifically mentioned in the Q&A, maybe that's a different national agenda. Therefore, a CET threshold uplift might not be even the most effective way. It could be one tool, but might not be the most effective tool to achieve the national agenda. Yeah, so that's what I wanted to add on.
Thank you, Poka and Beth, for weighing in on that component. Perhaps now reflecting on the other side of the aisle for HTA agencies and turning to this part of the world to Dr. Vanrudy. There's a question in the chat about how transferable going forward will NICE's recommendation, which is often either seen as a gold standard or benchmark for many countries. How transferable do you think this will be, both for Thailand, but also for other countries in Asia?
Thank you, Sonamini. I think in this comment, thank you to the person who shared. I think they summarized nicely in the first part how NICE has an excellent reputation to evidence appraisal, transparency, and quality of guidance and stakeholder engagement. And according to what John said, I think we shouldn't forget that, right? Like, I think John, in the preparation meeting, you highlight about the keeping the soul part. Recognize what Carl just said about how we may heading to not the so sunshine part, but still, given the situation, we do not see that what the lesson that we can still learn from NICE, from UK will be any less. Every time we learn or we look at evidence appraisal, any information, certainly we are very mindful on the importance of contextualization. So it's not that we just say, oh, NICE say yes, we say yes. It was more about let's look at what they find and let's learn from that. And for the other part of the question around, could this happen to Thailand? I think this could happen anywhere, right? And in looking back, may not be in terms of influencing the threshold, but have we received political pressure to influence reimbursement decision on certain intervention? I'm pretty sure, you ask any HTA agency around the world, of record, they will easily say yes, and the question may be more in terms of how often. So it hasn't come to that stage that we have policymakers who want to adjust the threshold. But perhaps I can finish my answer with a question back to Carl, John, Polka, Beth as well. As you hear a little bit more about Thailand situation, we've been asked, and I know for a fact, we are going to be more pressure. And I'm certain Thailand is not the only country who will face this situation. Is there anything you think we can do now? Can we do something? Can we be more proactive? So not to prevent it, but at least to minimize the chance of it happening. So thank you. And I see both Carl and John hands up.
Thank you so much, Vanrudy, for setting that up. Carl, perhaps over to you first and then to John.
Okay, so what I'd say is I think the UK has been especially vulnerable for two reasons. Number one, our dependence on our financial sector and the threat that AstraZeneca can make in that respect, which is what really lies behind this deal. That's number one. Number two, we've also been vulnerable because NICE has influence around the world. So if you can pick the UK, and in particular, it's not just about the money. If it was just about the money, they didn't need to change the threshold. They could have just changed the rebate. It's not about the money. It's about the threshold, because they know that has an impact on the rest of the world. That's why we've been vulnerable. That's also telling us that other nations won't be quite as vulnerable as we have been. Nonetheless, the pressure will be applied. How to push back against that pressure? I think what's important is to give those in government that advise those in these negotiations the weapons and the evidence to push back, or at least to be informed about whether it is worth conceding to these demands. That's the evidence that we've been able to develop in the UK. Unfortunately, our political masters are not really listening to that evidence right now. I think the other thing that we need is a long-term sustainable solution and have that vision. And the vision of that long-term sustainable solution has got to be mechanisms that allow the kind of price discrimination that Beth was talking about, without worries about reference pricing or about parallel trade. I think the other thing that we can do is to think more generally that actually we need to separate the functions of HTA from price and reward mechanisms for pharma. As John said, NICE does a very good job at the assessment. That is the soul of NICE. Let's keep that. But NICE has also been given this other job to negotiate price, and it hasn't been given the tools to do that job very well. So we need to separate these things, keep the assessment, but then have a reward mechanism that makes sure we give manufacturers 20% of the long-term value. And we can do that in a number of different ways. It doesn't have to be price. It can be a whole host of different mechanisms like subscription models or dealing reward structures. So I think that's my take. Is I think you are less vulnerable in the UK. I think pulling together the evidence to allow those that are at the sharp end of this negotiation to push back, and then to provide a broader vision about how something sustainable could actually work.
Thank you, Carl, for already setting us on the path of mechanisms. I do want to say that perhaps we might go over about 5 or 10 minutes maximum beyond the hour, given some of the responses. So those who are able to stay, please do. And I'll turn over now to John, then Poka and Beth, please.
Yeah. It's a downside to letting Carl go before he says most of the things that I was going to say. But I think the key thing is that agree with Carl. I think Carl mentioned it in his presentation. Is that the US are overpaying for products, and the kind of mantra seems to be, well, the rest of the world kind of has to compensate to compensate that situation. So Thailand, other countries, we're having discussions with a number of international markets, as you can imagine, as a result of that. Two things that I'd pick up on what Carl said, and hopefully it's come through my presentation. I think the most important thing is that you have the vision, long-term vision on where you want to go next, and retaining those principles. And the other thing Carl mentioned, and it seems that we live in a world where you can just dismiss evidence, right? You can just ignore it. You can not putting any particular president in the US under the spotlight, but you can just make a statement and it doesn't matter. Evidence is so crucial to doing what we need to do, right? You need that evidence. You don't always have to accept everything within that, but you at least have to acknowledge what it's telling you to ensure that you're going to have a sustainable future policy. And that's really, really important. My other advice would be, is if you give concessions away, don't expect that. Right? It's a constant. Well, if you give the bully the sweets, they're going to be back the next day, right? So I think whatever we do, it needs to be a balanced sort of policy approach based on evidence with a long-term view. And most important thing for me at the moment is making sure that we have a calm operating environment that's evidence-based, academic spine, and it allows HTA, the environment, to flourish. And that will allow us to sustainably evaluate pharmaceutical products and make sure that we're bringing the most important benefits to patients.
Thanks, John, also for highlighting the broader context in which you operate and how that would work going forward. Poka, and then Beth, please.
Yeah, sure. Thanks. So I will keep it really short. Just be mindful of the time. My advice will be actually 3. The first one is really needs to strengthen the local HTA capacity to ensure that your decisions are based on the local evidence and priorities, and not overly reliant on external benchmarks. So this is going to defend your decision. And then the second thing is actually relate to what Carl and John mentioned, is to have a long-term goal, to promote the transparent and context-specific, maybe a value assessment framework that reflect on your long-term national healthcare goals. So that's going to be very helpful. And then the third thing is actually what we are doing right now is to foster public dialogue on the healthcare priorities and also the trade-offs involved in funding high-cost technologies. To foster such public dialogue, or for example, foster even regional HTA networks, can really open the dialogue and the communication so that each stakeholder can understand each other better so that we achieve hopefully a better result for every side. So that's from my side. Thanks, Sudanini.
Thank you, Poka. Beth, please.
So my advice would be to get ahead of this a bit and to work up, like Carla's done for the UK, a clear picture and a transparent picture of what the consequences of this would be expected to be. To get those numbers into the public domain, and to use those numbers to hold your decision-making constituents to account. I think the other thing that might be helpful in this situation is to open up a discussion about, I guess, win-wins, things that would be in the interest of both the industry and population health. And this could look at ways to combine rigorous price regulation like you have with expanded access. So that could be how can we reach more of the eligible population pool with cost-effective medicines, and also about how we can provide earlier access whilst also having that careful price regulation. And hopefully that might allow you to push the conversation in a more productive direction.
Thank you, Beth. Based on that, I would like to ask Carl one question. What you mentioned about putting evidence in the public domain, and some other colleagues have also mentioned that. And Carl, you and colleagues at York and elsewhere have tried to do that to push the conversation forward. Are there any lessons in terms of communicating with the public? You shared a lot of the evidence that you have on your hands. How has that experience been? What can we do differently as HTA agencies and also as researchers? And second is in terms of working with the media as well, because they can also be potentially potent interlocutors when it comes not only with the public but decision makers. So any reflections before we perhaps go to a final round to all to hear about something that you'd like to see happen next from this discussion before we close? So Carl, over to you first.
Yeah, I think for some time, so we have customers in the Department of Health, Social Care, NHS England, and other arm's length bodies. And for some time, we felt that was the route by which our research could inform policy. I think what we've realized over recent months is that that is still an important route, but it cannot be the only one anymore. And we have tried to engage more publicly. We've done that as a strategic decision because we feel like, in a sense, democracy has been subverted, really. People have been, the truth has been hidden. And we have tried to do that in a number of different ways. We've tried to do that through our own kind of academic community, but that's not the really important community. The important community are twofold. It is backbench MPs in Parliament, and we've been briefing them and finding backbench MPs who are willing to ask questions in Parliament and to also inform them and help them formulate questions, and particularly the which scrutinise spending departments, and also the OBR, which looks at the kind of treasury and the fiscal stance of the government. And we've also tried to engage with the media as well. And that has been especially difficult, incredibly difficult. It's been very, very difficult to get this story out. We've tried extremely hard. And we found that we often get journalists who are extremely enthusiastic about this story. And then guess what? It either doesn't come out, it gets killed, or what you see published is a highly redacted version of what you knew the original article to be. And it's been quite depressing. There's a reason why rich people spend tens and hundreds of £1 millions on newspapers that make a loss. And it's not because they seem to have lost their business acumen. There's a reason. And I've certainly felt that over recent months. But you've still got to try. And I think bit by bit, hopefully, this story will get out in the way that I believe it deserves to get out. I actually think Donald Trump, in his recent statements about France, is going to help us in that respect tremendously. So thank you, Donald.
Thank you, Carl. So on that note, before turning back to all speakers for their final message before we close, I'd like to ask if Dr. Suvit, if you're still on, and if you'd like to share any comment. If not, may I ask Dr. Wang Yi if there's anything else you would like to add before we turn to the other speakers?
Thanks, Salamini. Yes.
Anything you'd like to add?
Okay. Yeah, thanks, Salamini. I think not too much from me. I think all speakers have expressed as an idea. So clearly, this is a complex issue, and the subsequent impact is unclear yet. And probably we do need more evidence, to understand the situation. And fortunately, we do have some experience from Thailand to understand the potential impact from the change in the cost-effectiveness threshold. But as mentioned, UKNICE probably is at a different position, in terms of its role model for the other HT agencies. But let's wait for the result, and hopefully, we can understand the impact better.
Thank you, Wang Yi. And as you also reminded me separately, there's a rich conversation on the Q&A on the chat. We know we cannot cover all of those questions today, but we hope we can get back to you separately and also find a more meaningful way to take this conversation forward. Before now, I shall maybe turn to all our speakers in the order that they spoke so that you know what to come in, because we are at the start of the year. We know this is an existential moment, as Carl called it, not just an inflection point of sorts. So something that you would like to see next? We've heard a few suggestions from you on what we could do collectively, but something that you would really like to see concretely come out of this discussion, or in the next from your colleagues that you can see to act on based on today's. John, shall we start with you?
Yeah, thank you, Samini. So just to be clear on the existential threat, absolutely agree. But I also saw a comment in the chat around surrender. I'm going to be very, very, very bold. Despite everything, NICE is still here. We're still world leading, and we still got a job to do. We are still going to do that job, and we're going to maintain our rigorous, evidence-based academic approach to health technology evaluation. But what's come out today is all of us collectively have a fight for our soul. And again, I can't find a different word to use it. And that's making sure that we've got an evidence-based academic spine, rigorous, transparent system, the principles of HTA. And what you ask me what the future looks like, it has to be based on that. And we have to preserve those principles, because it's only by preserving those principles are we going to have a stable operating environment that benefits not only patients, but also the industry as well. So again, in terms of what I'd like to see is, more sessions like this, more engagement, more dialogue, more public transparency about these things. And I'm sure collectively, when we come together, the future, even though I think Carl mentioned a little bit depressing in the short term, I'm sure it can still be very, very bright. Thanks.
I could agree more with John, and I'm also not hugely depressed. We're at a very appalling time right now in the UK, but in many respects, I think the seeds of something better might be sown in this crisis. You see, even the sector must know that if they're basing their future and their long-term investment plans over 10 years on the ability to continue twisting the arms of politicians around the world, that's not a very sustainable business plan. And I think many understand that, and we need a much more sustainable basis, both for healthcare systems and the sector. And I think that sustainable basis is possible by separating the functions of HTA, as John said, is about a rigorous assessment of the evidence from the question of, okay, what can we afford to pay to make sure we deliver a reasonable share of value back to the innovators? And can we have mechanisms that ensure that we can have the scale of price discrimination that's going to be required globally, so that all nations, whether high, medium, low income, participate in this market, get access to affordable medicines, and signal their needs to incentives for innovation and future R&D. I think the seeds of that may already have been sown, because at the end of the day, let's be very clear about this. This is taxation without representation. We know how that ended in Boston, and we need to get serious, that we need to fix this properly. We've allowed it, the political failure of really getting to grips with this has been decades in the making. This is not just about Donald Trump. It's not just about our weak political class in the UK. This is systemic. It's now time to fix it.
Thank you, Carl. Very prophetic almost. Thank you for sharing. And I also just want to say one more thing at this point before turning to Hoka and Vanrudi as well, that we know that this is a very fragile time for researchers and HTA agencies. And we want to know that part of the reason we are doing this is we stand in solidarity, and we'd like to be able to work together and find something productive come out of this. So just would like to also say that. Hoka, over to you, and then to Vanrudi and Beth.
Yeah, sure. Thank you. So I would also really just maybe reinforce what I re-emphasize what I said before. I think it would be good to foster more public dialogue like what we have right now, to really discuss the healthcare priorities and the trade-offs for funding high-cost technologies. So in the future, from my personal perspective, if we could develop and share more best practice for value assessment or price negotiation that are adaptable to lower resource settings, I think that would really be beneficial for all. Thank you.
Hoka, Vanrudi.
So I like to say thank you to all the speaker and the attendees as well, because I think from all the questions and your answer and the comment we share, I think there are certainly many to-do items, many things we can do. I think one specific point that looking in terms of Thailand is that information that you share today, I think it's very important for us to make it known to the HTA community in Thailand and also in Asia. So I think HITAP, we are part of the Secretariat team for the Health Economic Working Group under the National Drug Subcommittee. So that will certainly be one of the first, where Dr. Swee is the chair. So that will be one of the first place that we're going to summarize this information and then share. So, I think the more we get people become more aware, we can learn from what happened and hashtag, right? We stronger together. So thank you.
Beth, over to you.
Thank you. I guess I'd like to reflect on that I think we have common goals here. We want to support access, we want to support innovation, and we want to do that in a way that's sustainable. In my view, raising the cost effectiveness threshold isn't the mechanism to get us there. But I guess my reflection for the new year is the launch prices, which is what we're in a large part talking about today, are also not the only part of this really broad picture around price regulation for new pharmaceuticals. And I'd like to see more of a focus on how do we deliver access and a more imagination about that. So can we look to some of the positive work that's been done around voluntary licensing and other types of innovative models to try and promote access alongside careful price regulation? And can we also look to how we can ensure that healthcare spending is sustainable across the life cycle. So how can we make sure not only that we're regulating prices at the point of launch, but that we're getting generic and biosimilar medicines available at good prices and in a timely fashion, so that we have that overall value across the life cycle. So those are my New Year's wishes and resolutions, I guess.
That's a nice way to put it, Beth. We are close to now a little to the end of the time that we have already, and really appreciate you all sharing your aspirations with the group that's come together here. Some key points just to summarize. One is that going forward, we are likely going to need to adapt, whether within country or across countries, and this is hopefully a good starting point for us to think. One clear message is that we might need to think beyond our traditional scope and see the impact beyond the health sector as well, or at least understand better the implications for it. Consider longer term solutions that we could undertake and mechanisms that could make a meaningful change without compromising principles that HTA is based on in the long term. And also in terms of being able to engage with a broad range of stakeholders, and hopefully this conversation today and those of you who are here will be able to take forward and connect more with other groups within your own countries, region, or beyond as well. With that, I'd like to say a very quick vote of thanks. First, perhaps to those who are not on the screen, Dr. Tiravatananon, who initiated this webinar process after the news was announced. So want to thank him for bringing us all together and for initiating this. Ryan Sitangang at HITAP, who helped organize this session and putting everything together within a very short time frame, together with our excellent and esteemed speakers. So really thank you all for stepping up again on a very short notice and preparing things during the holidays to make this possible, because as you said, we wanted this to be a timely discussion and you have made that possible. And I think the attendance today is testament to what we were thinking together. Thank you also to Dr. Suvit for framing this discussion within the context of what this means for policymakers, especially for those of us in Asia, but also globally, and to the co-hosts of this webinar, as well as partners who help support having it today. So with that, what I will say is that we will share a follow-up email to all of you, a request for some feedback on today's session, and also ask for any suggestions for how we might take this conversation forward. And if you would like to have or quote anyone from this webinar in any external discussion, just given the nature of the topic, we ask that you request consent from the speakers, and please feel free to reach out to us to connect you to the speaker as well. With that, thank you again, everyone. Wishing you a happy new year and a productive and impactful year ahead. Thank you, everyone.